kidney failure encompasses a whole lot. We got acute kidney failure, we got chronic kidney failure. So all of our exemplars can lead us to kidney failure. So we're going to talk about how that happens and what we're going to do for somebody. So on kidney failure, we have a lot that I've drawn up here. So first off, we're going to talk about the stages of kidney failure. There's 4 stages. There's going to be a whole acronym called RIFLE. I hate that thing because they literally were square peg round hole. Like, it just don't work. It looks weird. I don't like it. So we're going to go to the more basic one, where it's just stages of kidney failure. So the first stage of kidney failure is going to be the initial or the injury. So this is stage 1. We're down at baseline, we have no symptoms, but something is going to happen to cause the kidneys to not function. So we're going to have either, if you want to call it the initial stage or if you want to call it the injury stage. I've seen it labeled both ways. I tend to like the injury phase just because it gets in your mind like something happened to cause a problem. So in this phase, we have 3 different sections. So this whole side of the board over here is all injuries that can start this process. We have 3 broad categories. We have pre-renal causes. So this mainly has stuff to do with blood that are going to cause an injury to the kidneys or perfusion. We have intrarenal causes. So this is stuff that actually happens in the kidney that makes them shut down. When you read about intrarenal, it's also called ATN or acute tubular necrosis. So when you read those words, know we're talking about intrarenal damage. And then we have post-renal damage. So this is mainly has stuff to do with urine. So what I want you guys to do is take just like a minute or 2. Like don't look it up in your books. Obviously we're going to go over it here in just a second or on Google. But I want you to just think of things that could fit into each of these categories that would cause your kidneys to shut down. So we're going to put causes up at the top, and then down at the bottom, we're going to put ways to prevent. Because a lot of our care as nurses always is going to go to how can we prevent the kidneys from failing? Because the kidneys are complete and utter divas, and they will shut down for literally no reason. So we're always working to protect those kidneys. Like it is a constant struggle every day taking care of a patient. Protect the kidneys, protect the kidneys, protect the kidneys, because they like to fail. So take a few minutes, think of things that we can put in each category, and then we'll talk about how to prevent it. So talk amongst yourselves, think of things, just a minute or 2. Which obviously if you should take one of your books, so you can see that later. I'm going to hold for just a minute on that one. So we know. Sepsis. Okay? Sepsis. I'm going to hold on that one. I like it. I'm going to hold on it. I'm trying to see if I get like a more broad.
What was the first thing they said?
They said blood clot. Hypotension. Okay, I like that. Hypovolemia. Decreased cardiac output. Does wouldn't that cover hypotension, sepsis? Sepsis causes massive hypotension because of decreased cardiac output. So anything that causes loss of perfusion to the kidneys. Okay, so if we say blood clot specifically to where? Like where is the blood clot at? Like to the actual renal artery. So like you clotted off the renal artery. That's very, very rare, which is the only reason why I don't want to put it up here. Like because that's just such a big vessel, we don't see it that often. You usually see blood clots in smaller areas, like they lodge down in the little tiny areas in the coronary arteries or like in the lungs or up in the brain. So the renal arteries are just so big and they go straight into the kidneys. So we don't see those a whole lot. Not ruling it out, saying it won't happen, but not too. So decreased cardiac output, our big ones are decreased blood pressure, so hypotension, sepsis. Those are some of our big offenders. There's another big offender that affects elderly folks. What happens to elderly folks?
Dehydrated.
They get dehydrated. This happens to our elderly folks all the time because it's a normal sign of aging with your thirst mechanism. We have decreased thirst mechanism, and so they just stop drinking as much. So they get dehydrated extremely easy. What do we see in the middle of August when we have kids out here going to 2-a-day practices? Get very dehydrated. They can start having some kidney issues. So anything that causes decreased cardiac output, hypotension, sepsis, dehydration, all of those things are going to cause kidney failure. Very, very common. So how can we prevent this? Alright, it's almost like I equal O. Like keep fluid balance. If you're peeing out a whole lot, drink it. If you're sweating out a whole lot, drink back. So make sure you're staying hydrated. I can't put like increased fluids because obviously we have some situations like heart failure and things like that that can't increase their fluids, but they do have to maintain I equal O. So staying hydrated. Yeah, staying hydrated, staying hydrated, staying hydrated. What else? I'm gonna throw up another one on here too. If your arm gets chopped off and you start bleeding out. Your kidneys can fail because your arm got chopped off because we're hemorrhaging out and losing a lot of fluid. What about patients who take a lot of NSAIDs? What are they at risk for? If you take a lot of NSAIDs, what are you at risk for? Risk for GI bleeding and ulcers. So you can have a bleeding ulcer to where you then have decreased cardiac output because you've hemorrhaged. So if we're hemorrhaging, stop the bleed and replace. So that kind of goes in with the I equal O. So I wanted to kind of put those together. So if we're having hemorrhaging issues, if we're having GI bleeding issues, and we're losing volume, we need to figure out a way to stop it, stop the bleed, and replace the volume that's lost. Okay. What about hypotension? What if it's not volume related? Yeah, we may need to do something like pressure medicines, which we're going to learn about in perfusion. So I'm just going to say correct decreased blood pressure. So correct any hypotension. So fun fact, all of our patients that experience a cardiac arrest, so anybody that gets CPR that's had a code blue, are going to have some degree of kidney injury. It may be very minor to where we really don't see evidence of it, all the way to complete failure to where we're in the whole AKI process. So any type of hypotension, if the kidneys do not get perfused, they're going to be like, well, you didn't perfuse me, I ain't working for you. So, and they just give up and go home. All right, what are we going to put in intrarenal over here? Did y'all have a big blank spot, or did you put something? All right, so I'm going to say the itises that we talked about, glomerulonephritis, pyelonephritis, especially if we chronically have them, right? Because they're going to cause that scar tissue formation. So yeah, chronic infections, chronic inflammatory processes. Okay, I'm going to broaden that out and say meds. And that's one of them. CT contrast dye. Y'all know that. That destroys kidneys. What other med can I put on here? Yeah, your mycins. Anything that is nephrotoxic, and your gentamicin, vancomycin, daptomycin, all of those mycins are very nephrotoxic. I had one lady in kidney failure, she said she took one dose of vancomycin, told her to shut her kidneys down. So, all our mycin, very nephrotoxic. The those are our biggest ones. So these are going to cause acute tubular necrosis, which is what intrarenal causes are. So what can we do to try and prevent that? Okay, avoid nephrotoxic things. Alright, can we avoid that all the time? No, because sometimes we have to have it. So how can we make sure if we have to have vancomycin, how can we make sure we're in a safe therapeutic range? Okay, regular lab work, which is called what? Peaks and troughs. How often do we do peaks and troughs? Okay, so your trough is your before, so you're going to pull your trough level. If it's too high, we're going to hold the dose. If it's within normal limits, we're going to give it. And then we draw our peak after it's finished. So 30 minutes or to an hour. It depends on which medication, if it's 30 minutes or an hour. Don't worry about that. It's just trough is before, peak is after. How often do we do peak and trough levels? We can't do it with each dose because we don't have time to get therapeutic. Every third dose. So we can't do it after every single level because it doesn't give your body time to adjust and get therapeutic. So we usually do peak and trough levels with the third dose, maybe at the sixth dose if it was off, but if it looks good, we may just leave it with that. So you can do peak and trough levels so that we don't give them too much. So those peaks and troughs can help them adjust the dosage to where we can use the lowest level possible with those antibiotics. Because the standard is 1 gram. Everybody gets 1 gram of vancomycin. Have y'all seen people get like 750 milligrams of vanc? It happens. Most of the time, they got to have like 1,500. They need a higher dose because a lot of it's based on weight and how bad the infection is. But lowest level of nephrotoxic med possible. All right, what else can we do? Let's prevention with this contrast dye. What can we do to prevent damage from contrast dye? All right, so I'm going to say for the dyes, fluids. So typically before somebody has an IV contrast test, a lot of times the pre-orders are going to say start an IV and you're going to start some fluids so that they're nice and good and hydrated prior to the procedure. So a lot of times they also even want you to draw BUN and creatinine so we can see the baseline BUN and creatinine, and if it's elevated, we're going to add a few things to protect their kidneys because sometimes we've got to have that test with the dye, and so we're going to add a few things to protect their kidneys. So has anybody added some things to the fluids or seen it added to fluids to protect the kidneys? 2 meds. Yep, acetylcysteine. Alright, so acetylcysteine can be given. It's on your on Canvas on your medication list. So acetylcysteine can be given. A lot of times it's given PO rather than IV, but acetylcysteine can be given because it protects organs. We're going to see acetylcysteine again in medical emergencies because it also protects your liver from Tylenol. When we have people do Tylenol overdoses, it protects your kidneys from contrast dye. So all acetylcysteine does is there's all these receptors on your organs that like to go out and grab medications. Well, acetylcysteine is going to kind of like be what it grabs. Rather than grabbing the contrast dye, it's going to grab the acetylcysteine, so it protects your organs. So acetylcysteine is very organ protected. If you're going to drink it, which most of the time you're going to drink it, so I'm going to put the, a lot of times you have to drink it. It smells like rotten eggs. Anybody smelled it? Nobody? Anybody walked into somebody having a breathing treatment and you thought maybe they had bowel movement because they were getting a mucus breathing treatment? Okay, I see a head shaking. Acetylcysteine is also mucomist, so we give it in a breathing treatment. And so sometimes you walk into a room and that breathing treatment has been stuck up the room because it smells like rotten eggs.
Where did you say this was located?
It should be on the to-do list with all your medication. Should be on there. Should be on there.
Why would you not give acetylcysteine before contrast dye?
Because it tastes like garbage and people might throw it up, so we usually just give it if they have high BUN.
So if everything looks good, you would just do the contrast and drink fluids?
Because most of us, as long as you have good fluids from a flushed up, our system just fine.
And BUN and creatinine, when it goes up, like obviously that's kidney problems, what happens if it's on the low end, or do you
One of
just
the
not
time
see
that's
that?
like dehydration or some other things where we're having some other organs causing us some problems, that usually we don't really worry about it if it's low.
It's when it's high. that
It's when it's high.
not
That's when I
functioning.
care about it, when it's high. So my recommendation, if you've got to give this to drink to somebody, mix it with like Coke, Dr. Pepper, like something strong to kind of overpower the stinky. Like, don't give it to them with juice. Not egg juice, no. Like, give it to them something strong, and then just go ahead and warn it. Like, throw it back really fast. Just get it done, because it smells awful. All right, other things we can add to fluids. We can add bicarb to fluids. So our kidneys make bicarb, so we're just going to boost up that bicarb to try and help protect the kidneys. So again, this is usually just if the BUN and creatinine are elevated. And then if we have glomerulonephritis and glomerulonephritis and pyelonephritis, what are we going to do if we have those? We'll treat them, like compliance with treatment. Treat itis. So be compliant with your treatment, be compliant with your prevention, like all of your UTI prevention stuff. Making sure we stay on top of those strep throat infections, and if we start seeing any signs of like blood in the urine, like coming in really quick and getting that treated. All right, post-renal. What are some things you can think of here that would go in this category? This is like urinary type problems. UTI. Right. UTI, because UTI a lot of times causes urinary retention. Kidney stones is a big one. Big one is kidney stones. This is why a lot of times we end up having to put in nephrostomies, because the kidney stone has blocked the ureter, and we've got to get that urine out, because if the urine doesn't come out, we're starting the AKI process. We've got to get the urine out. So that's a big reason why we may have to have a nephrostomy. What else? BPH, that's a big one. You can say prostate cancer too, but BPH is by far the more common issue that we see. So blocking urine from leaving. What else? All right, so we're just going to say anything that blocks the urine from leaving. So anything that causes it, so any type of urinary retention, that we don't get the urine out, blocked Foley catheters, anything. So we're going to say for Foley care. One of the worst patients I've ever had with AKI was from, it came from Foley catheter mismanagement. So I had a lady that came in, she came into the ER, she was a home health care patient. She was taken care of by family at home. She had an indwelling Foley catheter. I don't remember why she had an indwelling Foley catheter. She was a paraplegic, so she couldn't feel below the level of her waist. A lot of times they'll do urinary diversion surgeries for that to try and prevent the need of a constant indwelling Foley catheter. So I don't know if she wasn't a candidate for that or she was waiting on that. I don't know. But she had an indwelling Foley catheter. She's at home, paraplegic, can't feel below the waist. Home health coming out like a couple times a week to take care of her, educating the family on how to take care of her. Family story. I remember his family story. Family says home health care came out to bathe her on, we're gonna say, a Monday. And they left the Foley catheter in the bed with her. Where's your Foley catheter supposed to be?
Below the bladder.
Below the level of the bladder. She comes in, we're gonna say by Friday, because the home health came back out and saw she was very, very sick and called 911 immediately. So the family says they left the Foley catheter in the bed with her. She got very, very sick because her urine wasn't allowed to drain out. I don't know why nobody else in the whole house didn't notice that Foley catheter was, y'all not empty it? You just leave it full all the time, so just get empty like when the whole health care comes out? But the lady can't feel anything, so she couldn't feel that her bladder was full, couldn't feel that the catheter was in the bed with her. So by the time she came to us, her urine was brighter than your leaves, green on your cup there. Super, like neon, glow in the dark, green, thick urine. They changed out the Foley catheter down in the ER, still wouldn't drain because it was so thick it wouldn't come out. She died within a day of being admitted to us. So the renal doc came in and said, I can't even dialyze her. If I dialyze her, the dialysis will kill her. So there's nothing we can do. And that was all because the Foley catheter was left in the bed with her. Because she had no other issues that she came with. She wasn't like diabetic, heart failure, like any of those other types of things. She just was a paraplegic and had to have Foley catheter. So our Foley care is extremely important to make sure urine is leaving the body. So what can we do to prevent post-renal failure? With cat care. Make sure we have appropriate use of Foley catheters. What else? Good UTI prevention. So all your good hygiene stuff, your no baths, taking showers, all that good stuff. Stay hydrated because that's a big one to prevent kidney stones, right? So BPH may need to have surgery for that, may need some medications, we got our Flomax, those types of things. So we're just gonna treat any of those situations. So treat BPH, UTI, etc. So we're gonna treat those issues. Basically, I want urine coming out of the body. I want the body to make urine, I want it to exit the body. It cannot stay in the body, so get it out. So you see we have a lot of different ways the kidneys can fail. Why is this important that you know all these different categories? What if somebody comes into the ER and their BUN is 8? I mean, not BUN, their creatinine is 8. We'll say their BUN is 80. Creatinine is 8, BUN is 80. Do you give them fluids or do you not?
Question, is that high or low?
High. Your creatinine should be 1 or below.
Oh, good.
You should not give them fluids. I would actually.
What if they're dehydrated?
Oh. What if they?
Depending on what's coming on. What if they got a dose of vancomycin yesterday? I give them fluids, I might kill them. But this person, if I don't give them fluids, they're could go into a whole world of trouble. So it's important to know the categories. I'm at clinical on Monday, which by the way, like if y'all email me on a Monday, just if I don't answer you, it's because I'm in clinical. So I'm in clinical pretty much every Monday. But we literally saw on one of our charts, pre-renal versus intra-renal versus post-renal AKI. And we were just laughing. I was like, well, that's all of them. Just pick like maybe 2 they could narrow it down to. But that's what the HMP said. It said pre-renal versus intra-renal versus post-renal AKI. So you might actually see it on some HMPs. Is there a question?
Why, you said if you give fluids to the person who has vancomycin, to go kill them.
It could potentially, I don't know, because theirs is caused by a medication. They may have normal fluid balance. I don't know.
I get what you're saying, okay.
But this person who's dehydrated, well, they're dehydrated, so it's important to understand like why the person started this whole process of AKI so that we kind of have a better idea of how to treat them. So all of that is phase 1 of AKI.
And you said there's no symptoms in this stage.
No symptoms in this stage. So an injury occurs. So we gotta know, so this is kind of like where we do some of our detective work. Like somebody comes in, they're not coming in on the injury phase. They're coming in to your ER in phase 2, which is the oliguric phase. The rest of this is gonna go a lot quicker. Alright, so this is where you're gonna see people because we go from baseline, no symptoms, no signs and symptoms, we're at baseline, and we're gonna do a sharp uptick to the oliguric phase. If I'm in an oliguric phase, what does that mean? What does oliguric mean?
Low urine output.
Not enough urine. So if I don't have enough urine, what are my symptoms gonna be? Broaden it out for me. Rather than give me individual symptoms. Okay, electrolyte imbalances, specifically which one? Hyperkalemia. Can that kill you? Yes. Sure can, real quick. All right, give me another major one. Okay, before we get there, that one takes a little bit of time to happen. It doesn't really happen like acutely.
What? I didn't hear what
They said acidosis.
Oh.
That one takes a little bit of time. It's not like super fast.
The high phosphorus.
Fluid volume overload. Oh, we know how to recognize both of those, don't we? So we did that last week. So your patient in the oliguric phase is your board that you did for fluid volume overload and hyperkalemia. So the calcium phosphorus issue, that one takes a little bit longer to occur, like that's not a super quick alteration. The metabolic acidosis takes a little bit longer to occur. It's not like super, super quick. These are gonna be what brings somebody into the ER. All right, so once they're here with the ER, then we're also gonna see, I'm gonna go ahead and write it out here, the metabolic acidosis and the decreased calcium, increased POTS. When I say metabolic acidosis, is that compensated or uncompensated? Because I'm in an acute process, so it's gonna be an uncompensated. All right, but they're coming in, a lot of times this fluid volume overload, that's the one that has the symptoms that patients come into the ER with because they start not being able to breathe. So, because they're drowning on dry land. So this is what they're coming in with. All right, so the oliguric phase. Can you die in this phase? Yep, this is a lethal phase of AKI. So oliguric, lethal phase of AKI. Do we know how to treat this person? We sure do, because we did all that last week. So we already know how to treat this person. We do need to tailor it to their cause. So if they're showing me signs of fluid volume overload and then I find out that they've had IV contrast dye, I don't need to give them fluids, right? If they're not showing me signs of fluid volume overload, but maybe just hyperkalemia, and it's an older lady who hasn't drank very much, well then I need to give her a whole bunch of fluids, don't I, to correct it. So my treatment is gonna be what we talked about last week, just tailored a little bit more to the finding out the cause. So I gotta bring both of those two things together. I gotta bring what we learned about last week, and I gotta bring the causes over here and bring those two together on how to treat them. My goal of care for the oliguric phase, don't die. So don't die, because this is lethal. All right, when you're at the top of this hill, you're in phase 2, the oliguric phase. Your kidneys have a decision to make. And I say your kidneys have a decision to make because nothing you can do is going to help those kidneys make the decision. Nothing the patient can do is going to help these kidneys make the decision. They've got to decide, do I want to stay here or do I want to get better? So let's say they get better. So they're going to start coming down and they're going to go into can swing the pendulum the opposite direction, and I can start getting fluid volume deficit. I could start getting hypokalemia type issues. So I can swing that pendulum right the other way. So I've got to monitor everything while I'm here. Okay? But this is telling me my kidneys are getting better. And then if we continue on, we're going to come in the last phase, which is recovery. And this is a 3 to 12 month process. This is where we're coming back to baseline. And our goals in this phase is don't start back over. So we're going to be all this prevention. All this prevention is what our goals in recovery phase. We want to avoid anything that could cause the kidneys to just start right back over. So avoid injuries. I don't want to start back over. That makes sense? Get out the way. Make sense on your phases?
Can you kind of go over phase number 3?
Okay, phase number 3 is the diuresis phase. That tells me your kidneys are getting better and they're gonna start producing urine. So they're gonna, usually they start just excreting water first. The filtration and the volume output usually don't come back online at the same time. So a lot of times they start putting out water, but you're still having electrolyte issues. So we're monitoring that constantly to make sure our filtration starts coming back. So we're just gonna be monitoring, make sure they don't get dehydrated, and make sure that they don't go into the opposite fluid or electrolyte imbalance. Like they can go from hyperkalemia to hypokalemia. So we're just trying to prevent this. We wanna stop it.
So where does dialysis come into play?
Okay, remember our care of don't die.
Okay.
So everything we did last week, remember we put dialysis as a last resort down at the bottom? So if I'm doing all that care that we talked about last week and it's not helping and my patient's is starting to get in danger, dialysis.
Okay.
So we're gonna try all those things first. So if we have a patient who comes in with their fluid volume overloaded, they can't breathe, what am I gonna do? What's the med that we can go to? Lasix. I'm gonna give them a huge big old dose of Lasix. And they can start breathing better. Great. What if they don't start breathing better? Probably not gonna help. All it does is open up the passageways. I give them some more Lasix. Hope for the best. But if they still continue fluid volume overloaded and they can't breathe and it continues to get worse, I'm gonna have to go to dialysis to get the fluid off. Same thing with potassium. If I give that Lasix, because that's gonna give me both aspects, right? It's gonna get rid of the volume and it's also potassium wasting. If that helps control my potassium, great. If not, and I start having cardiac issues, we might have to do dialysis. All right, makes sense? More questions? Because we're gonna have more scenarios. We're gonna do some examples of patients with this too.
Calling it 4 stages of renal failure is kind of discombobulating me, because
Okay.
the last 2 phases, the kidneys aren't necessarily failing, they're kind of recovering.
All right, so we kind of live in a prevention of this one all the time. Like we want to prevent any of these injuries occurring. So when I have my patients that come in with hypotension, I'm like, I gotta fix this hypotension because I don't want this to happen. So I'm working on preventing it. So I gotta prevent the injury at all times. We live in this world. These 2 are real easy, like those are, my kidneys have actually failed, so I'm working on it. This one, patients can have an elevated creatinine for that 3 to 12 months. Like it may take that 3 to 12 months before they actually return back to baseline. So this one, we may still have a little bit of symptoms, we may need maybe a little bit of diuretic, until they finally recover back to baseline. And then I saw you.
Will like the kidney tissue be scarred once they go into the recovery phase, or will they kind of like go back to kidney?
It depends on your cause. So her question was, are the kidneys gonna be scarred after they recover here? It depends on your cause. If your cause is because, you were hemorrhaging out, shouldn't have any scar tissue to speak of. If your cause is because you've had chronic pyelonephritis, you're gonna have some scarring. If your cause was due to some of these, like that's an infection, so maybe. Poor Foley care, like that lady, like it was super severe. Maybe if it caused a UTI. So potential scar tissue, probably not. Because this just has to do with more perfusion of the kidneys as opposed to the kidney tissue itself.
So in the oliguria phase,
Okay?
even after dialysis, if it doesn't work out, so will they be considered as a kidney transplant after that?
Okay,
part?
so that brings me to my next point.
Okay.
All right, so any other questions on this before I'm gonna go to where she's taking me?
Just to make sure that I get this, in the initials,
Okay?
your goal is, you said to take this, so you're trying to figure out that's pre, intra, or post.
Usually they're showing me symptoms, so I'm trying to like backtrack and figure out what caused it. Remember, there's no signs and symptoms. We're at baseline, but an injury happens.
So we don't really know.
Right.
Then they start showing symptoms as they go up the hill, and then you decide if it's pre, intra, post, depending on the treatment.
Like, as y'all are drinking water in here all the time, you are preventing an injury. Hopefully, that's what I tell my children all the time, because they won't drink water. I'm like, "Will you please drink water, your kidneys are gonna fail." It's rough having a nurse for a mom. All the time I'm telling them, drink water. I don't feel good.
That's what I was wondering, at what point is it like, goes from acute kidney failure to like chronic?
Okay, so that's where she was going. All right, so let's go, so the question was, how do we know if we're going from like acute to chronic or needed transplant? Okay, so I told y'all, when we get up to this phase, so an injury occurs and my kidneys shut down. We are officially in acute kidney injury. So they've shut down, we're in the oliguric phase. Your kidneys have to make a decision. Am I gonna get better? Or am I not? So if they make the decision, I'm done. I ain't working no more. Now, we stay up here. So, we're in the medical field, we can't have one word for something, we have to have multiple words. Don't know why. We're either an end-stage renal disease or chronic kidney disease, they mean the same thing. So, if my kidneys decide, I'm done, ain't gonna work, then they stay in the oliguric phase forever. And that is chronic kidney disease or end-stage renal disease. That's all that is. Patients who are in the oliguric phase. So they live with risk of fluid volume overload, electrolyte imbalance, metabolic acidosis. Like they live in that world all the time. So these are your patients that are either going to be a kidney transplant list or either your long-term dialysis. Now, there's two ways to get to end-stage renal disease. This is one way. We're going to talk about another way later. So, this is one way you get to chronic kidney disease. This is one way you get to be a lifelong dialysis patient. There is another way, the more common way, but this can happen. Yes, question?
So if they stay in that stage, does that become their new normal, like their new baseline?
Because now, if they're here, let's write in a different color. Now they are a dialysis patient. Forever. Unless they get a kidney transplant. So there is no cure for the kidneys. None. No cure at all. Dialysis doesn't cure. All it does, remember I told you our goal of this phase is don't die? That's all dialysis does. Don't die. It is not a cure. Your kidneys will not start working don't die, for your kidneys to make the decision, hey, you know what, I think I'll get better. And they'll start recovering. Your kidneys make that decision right here when we're in acute kidney injury. They make the decision, am I gonna recover or not? So the more comorbid issues you have, the higher risk you have of kind of staying up here. Like if you're coming to the table with severe diabetes, severe hypertension, severe CHF, and you have one of these causes that just kind of tips you over the edge and throws you into AKI, there's a strong possibility you may stay up here, and this is how you end up a dialysis patient. If you're a young person with no comorbid issues, non-diabetic, non-hypertensive, but say you had some glomerular nephritis that just couldn't kick and it threw you into AKI, really good chance of getting better. So it kind of depends on your baseline health, on if you're going to get better, if you're going to stay pretty sick. All that to say, I've seen 20-year-olds that have gone into long-term dialysis patients, and I've seen 100-year-olds that get better. So, you know, those are factors that every person's different. The lady that I told you guys that she had a pyelonephritis that was untreated, she was only like 30. Like she was really young. And she had no comorbid issues. She was completely healthy. But she went into severe AKI, and I think her kidneys finally recovered, but it took months. So she's on dialysis for a long time. All right, more questions?
So you can see dialysis patients' kidneys grow.
Only if they're AKI. Like if they get to a dialysis patient this way, there's two ways to get to be a dialysis patient. This is just one. So if it's this, because we can stay up here for a long time. Like I've seen people stay in AKI for months up here. They're on dialysis for months, but then they finally do get better and recover. So this phase can stay for a long time. But if they never recover from it, then we have to actually